everybody, and welcome to our webinar for today on neuropathic pain and spinal cord injury. I see a few people have logged on already, so we'll just wait a few more minutes to get a little bit more participation. Okay, so we're going to get started. Once again, welcome everybody. Today our webinar is on neuropathic pain and spinal cord injury with Rebecca Charbonneau from the Foothills Medical Center and Rob McIsaac, who is also an employee with Spinal Cord Injury Alberta. Just a reminder that the rehabilitation advice line is available Monday to Sunday from 10 a.m. to 6 p.m. And a short disclaimer, the information contained in these webinars and other related materials is not a substitute for professional medical advice, diagnosis, or treatment. So please contact your medical practitioners for more information and to see what is right for you. This webinar is being recorded and will be made publicly accessible. And a few housekeeping rules. Everybody will be muted. You will have an opportunity to ask questions and share your experience. So please make sure to use the chat box. We will keep an eye out for questions that will be discussed during the discussion period. And just also a reminder that during the discussion period, the recording will be turned off. So if you can take about 30 seconds, you will see 2 poll questions this time, and we'll give everyone about a minute to complete these 2 poll questions before we start the discussion. So you should see the second poll question pop up now, and we'll give everyone about 30 seconds to answer. Okay, so we are going to start our webinar today on neuropathic pain and spinal cord injury, and I'm going to pass it over to Rebecca Charbonneau. Rebecca?
Great, thank you, Zara. All right, can I have the next slide? And the next slide, yeah. So yeah, we're gonna start off our talk today with a case. So this is Mr. J.A. He's a 23-year-old male who had a fall while skiing 3 weeks ago. He had a C7 T1 fracture dislocation and a complete spinal cord injury. He's a C7 Asia A, complete tetraplegia. And prior to this injury, he was healthy, no previous past medical history. And as far as pain medications, currently he's on hydromorphone CR, which is the long-acting form, 6 milligrams twice a day. Next slide, please. So when asked about his pain, he gives a description of 2 very different types of pain. So the first type is at the surgical site, very sharp, achy, not radiating anywhere. Severity is about 6 out of 10. And this started immediately post-operative that he can remember. He does find the hydromorphone helpful for this type of pain. And it is interfering with his day-to-day life, but only a 2 out of 10. The next type of pain he describes is in his arms, and it starts from the neck and radiates down the C8T1 dermatomes. So on the arm, that's from the inner elbow down to the fourth and fifth finger. He describes this as burning, lancinating, electrical, cutting, extremely severe, and he noticed this immediately after the fall. He can't really think of anything that's relieving it. He is trying a short-acting narcotic that's taking the edge off, but really not helping with the pain. And this is interfering with everything he's doing day to day. So 10 out of 10 interference for his mood, his sleep, and his ability to concentrate. Next slide, please. So when it comes to pain after spinal cord injury, there's lots of different types. So we use this standard classification, and there's 3 tiers. Next slide, please. And so if I can draw your attention to the top 2 types of pain in tier 1, nociceptive pain and neuropathic pain. Next slide, please. So when it comes to the nociceptive pain, this is pain that's from injury or disease to muscles, bones, organs, tendon, ligaments, arthritis. And this type of pain tends to respond to medications like Tylenol, anti-inflammatories, or narcotics. Next slide, please. For this talk, though, we're going to try to concentrate on neuropathic pain. So after spinal cord injury, this is broken into different subtypes. So if you look at the diagram, the middle one, so the red one with the band, that would be considered at level spinal cord injury pain. So for instance, if someone had a T6 level injury, they might describe a pain right at that injury level. And this can be for any level of spinal cord injury. And then the other type that's very common is below level spinal cord injury pain. So if you look at the blue diagram, this one is pain that can occur in even areas where you might not have sensation to light touch or pinprick. You can still get pain there. And this is from, or thought to be from, spinal cord ischemia, and the signals just aren't getting through there correctly. Next slide, please. So overall, neuropathic pain is any pain that's caused by a lesion or disease in the somatosensory nervous system. And this is the nervous system responsible for feeling things like light touch, pinprick, joint position sense, and vibration sensation. Next slide, please. It's very common after spinal cord injury, so it occurs in 1/3 of patients with the below level neuropathic pain. And then almost half of people with spinal cord injury describe at level neuropathic pain. This is the most common complication after spinal cord injury, and it's very important, and it interferes a lot with things like sleep, ability to do rehab, ability to return to work successfully, quality of life, as well as participating in the community. So any of the social activities or activities that are important outside the home. Next slide, please. It's often quite difficult to achieve 100% pain control as well. So in this talk, we're going to talk about managing pain and trying to reduce it. But I think it is often difficult to get down to a 0 out of 10. Next slide, please. With regard to management, we do turn to the literature and the evidence that's available. These are the most recent Canadian guidelines for treating neuropathic pain, so we will be referring to this throughout the talk today. Next slide, please. So when it comes to the initial assessment, this is also recommended to be standardized. So we use the International Spinal Cord Injury Pain Basic Dataset. And this is either the tool that's used or something very similar. And often the healthcare professional will ask questions about the pain. So for instance, describing the location, when was the onset, how has it progressed over time? Has it been getting worse, better, or staying the same? What the timing is, like for instance, is it worse in the morning or is it worse after activity? Is it worse when you lay on your stomach or sitting in the chair? what the quality is. So is it sharp, or is it dull? Is it lancinating? Is it electrical? What makes it worse? What makes it better? And what's the severity? As well as reviewing for any red flags that might point to a more sinister cause of pain. With this assessment, it helps to make sure that we're talking the same language and that we're identifying the correct type of pain, as well as starting the correct management. Next slide, please. So once the pain has been assessed, then we dive into management. So generally, we try to use both non-pharmacologic and pharmacologic strategies, and go in a stepwise manner. So rather than starting like 8 things at once and not knowing what's improving the pain and what's making it worse potentially, it's important to do things sort of one at a time, as well as use an interdisciplinary team approach to manage pain. Next slide, please. So there's several different domains. So here it shows sort of 5 different options or approaches, and we'll discuss each of these in further detail in the next slides. Next slide, please. So the first one we'll discuss is physical treatment and intervention. So, this could be simple things like working with a therapist on wheelchair modifications to help address pain in this fashion, or reviewing transfer techniques or wheeling techniques. These can help with things like shoulder pain as well as with neuropathic pain. Physical therapy can be very helpful, reviewing things like stretching, strengthening exercises, aerobic exercises, as well as a home exercise program that can be done on a routine basis. Other modalities such as acupuncture can be quite helpful. And then exercise has really good evidence for helping to reduce pain. And there's other options such as TENS machine or other functional electrical stimulation. Next slide, please. The next domain we'll talk about is psychological intervention. So these would include things like relaxation and biofeedback, cognitive restructuring, so cognitive behavioral therapy, as well as individual psychotherapy, hypnosis, visual illusion, meditation, mindfulness, all are very important. So these are skills that can be taught with a healthcare professional with training in these various therapies. So this may be a counselor, social worker, psychologist, a psychiatrist, or another physician to help you learn these skills that need to be practiced. Next slide, please. The next sort of pillar we'll talk about is medications. So going back to the evidence, the best evidence is for the anticonvulsant type medications. This is level 1 evidence, the highest level of evidence that's available. And these would be medications such as gabapentin and pregabalin. So very commonly used. Other medications that have been shown to be helpful after spinal cord injury for neuropathic pain include antidepressants such as nortriptyline or duloxetine, as well as anti-inflammatories, opiates. If spasms are causing the pain, antispasticity medications can be quite helpful. And then there's other topical medications such as Voltaren, lidocaine, topical gabapentin, if the pain is more focal. Next slide, please. And then prevention and self-care cannot be understated. So overall health can have a big impact on pain. If a person is having lots of bladder infections, lots of bowel problems, any issues with skin breakdown, spasticity, sleep problems, all of these different complications can make pain worse, and they can make pain more difficult to treat. So it's really important to touch base with your healthcare provider and get some of these underlying health conditions managed and treated in order to get on top of pain. It's also important to be mindful and sort of keep a record of pain. For instance, identifying what activities are making things worse, what kind of things you're doing that are making it better. So you have a good sense for yourself, as well as to communicate to your healthcare provider about these things. Next slide, please. So the overall or overarching strategies for managing pain after spinal cord injury. When it comes to medications, starting really low and going up slow is very important. And the reverse is true. So if you're titrating down medications, also going quite slow to make sure you're aware of how the pain is responding. Using a combination of therapies to optimize the pain management is a better strategy than just doing one thing. So for instance, if you're just doing physical therapy or just doing medications, you kind of want to use things in combination. Education around pain is very critical. So this is like anything after spinal cord injury. It's really important that you have knowledge about it yourself so that you're able to self-manage, as well as work as part of a team member in the management strategy of pain. And then frequent and routine assessment and monitoring for effects of therapy on a regular basis is also important to maximize outcomes. Next slide, please.
Thank you, Rebecca, and for the wonderful presentation. I did forget to mention, Rebecca is a physiatrist at the Foothills Medical Center, so my apologies for not mentioning that at the beginning. I will now pass it over to Rob, and he will share his experience with pain management. Rob?
Thank you, Zara. So as you can see, my name is Rob McIsaac. I am a registered social worker. I work as a client services coordinator with Spinal Cord Injury Alberta. I have over 16 years of lived experience as a C5, C6 incomplete quad, Asia C level, so again, incomplete. So just a little bit about my story and management of pain. So at the time of injury, from what I remember, there's the two different types of pain, just as Rebecca talked about, when you come to muscle and joint pain. For me, I could feel it severely in my neck, which was site of injury, as it was caused by a traumatic motor vehicle accident at a high rate of speed. So with that said, it was explained to me that, muscles can contract to kind of help the body a lot and stiffen up or such things. And that's where it became really, really painful in those regards. That was the major thing that was bothering me at the time. So what I had for pain was the hydromorphone, a long-acting one, as well as I had Dilaudid almost every 4 hours for the breakthrough. So as time went on, and I noticed that it was really interfering with my activities of participation in physiotherapy and occupational therapy at the time. So that's when I spoke to physicians about getting rid of those medications for that kind of muscle pain. And as I was able to participate more, it started to alleviate the pain in the muscles and all that stuff. So then came the point where that's when I started noticing the burning, the tingling sensations throughout. And for me, it's below level. So throughout my whole body, mostly my feet, my calves, I feel it a lot, sometimes my knees. So it kind of fluctuates a little bit depending on my day. It's not something that is always the exact same. So like when I find that the longer I sit still in stationary, that it will increase. With that, it's kind of been an up and down thing for the last 16 plus years. So it's not something that just always stays the same. It can go up or down depending on the day, depending on what I'm doing. If I'm in my office all day long working, then I notice an increase in the neuropathic pain, especially in my fingertips. And it gets really, really annoying. So we can go to the next slide, Zara, please. So previously, I used to suffer from it a lot, to the point where before working or anything like that, that it would keep me from participating in daily activities, regular things like getting out of bed or getting dressed, because it was just, I was so fixated on that pain that it was enabling me from being anything within my community, right? Getting up and having a good time, going for a wheel walk, whatever. And then, I started developing, just as I said, anxiety, depression, social isolation. And these are things that can be very common for a lot of individuals suffering with neuropathic pain, because you come withdrawn from everything and you start to just start to fixate on that pain and trying to fix it. Obviously, we can't just fix it, right? We can only put in measures to help alleviate that. And, that's something I really discussed with my physician, not just one, but a couple, my physiatrist, my GP, and started, as I said, go slow, start with the medication, which is what I did. And to point out too that this here, as I'm discussing these things with the neuropathic pain and the treatments for it, it's very, very individualized. It varies between one individual to the next, because as we know with spinal cord injuries, not everything is the same, right? We can have the same level of injury, but still different physical function. We feel different sensations, different pain sensitivity. So that said, it's not one of those things that, a friend of a friend that does this for the treatment and it works great. You should probably consult a professional, if it's something that you want to try, because just because it works for one person doesn't mean it's always going to work for you. It could hinder you even more. So that's why I highly recommend seeing a professional in these fields. So like for me, as I said, with the physiatrist, started with medication. I was on a lot of gabapentin at one time. I still take it, but very minimal, because I started a combination of the medication with physical activity, meaning, from regular weight exercises to stretching routines to just wheeling, getting a good blood flow and circulation. Found that not only did it help my nerve pain, but it also helped with spasticity, which at times when I get spastic, that it increases my neuropathic pain, especially in my feet and hands. For some reason, it's always my feet and hands. The next step I incorporated into that was a psychological approach. Something I never believed in at the time of injury. It's not something I would have just went out of my way and think it's a bunch of voodoo hocus pocus that, it's not really viable for me yet. But now that I have time to think about it, and not only that, practice it, even more so after I got into the professional field that I did of social work to learn these skills. And for me, it's mostly mindfulness and meditation. Mindfulness, just mental training, right? And just teaching myself how to slow down racing thoughts, because I also suffer with anxiety. So again, I take a minuscule amount of medication, which now that I know and have had the time to discuss with Rebecca through this presentation, that some anxiety medication can also help as well. So that's another triggering thing for myself, that when I find that I am getting anxiety and I recognize that I also notice the side of the neuropathic pain more, notice the further increased tingling. And to me, it's the reason I notice is it because of my self-awareness. So I'm able to be self-aware of my body and mind. So even to the point that if my feet are misplaced on my foot plate, that it can cause that neuropathic pain to kind of increase. And getting back to the psychological part, that's when I'm able to recognize that I'm fixating on that and focusing on that neuropathic pain. That's when I'm able to use a couple different mindfulness techniques, which I use apps for. There's many different type of apps that you can have on your phone, just to kind of center yourself and focus on breathing techniques, and try to more so practicing a lot of different breathing and grounding oneself. And, it's practice that can pull you away from feeling negative emotions, and it can help distract you really from what you're experiencing at that time. So again, consulting with somebody such as a psychologist or a social worker that is really good with it. They have all these different techniques that you can utilize. And I know, and they're very simple techniques, but they do take time, to practice. And it's one of those things, practice makes perfect, but it can always change. I can use one example as the point where I was on a very small amount of gabapentin. I ended up having an emergency surgery just due to something out of the blue. And because of that, I was on bed rest for a while. And due to that inactivity, my neuropathic pain and spasticity went just uncontrollable. And this was probably 5 years ago. So going from small amount of medication, being physically active, managing my own pain, and just being like, it's just another day, to all of a sudden waking up and it's like, I can't deal with it. This is awful, to having morphine for breakthrough pain, to quadrupling the amount of baclofen and gabapentin I was normally taking, because just needed to get rid of the pain, because it was just enabling me from participation in even just stretching from that point. However, after that is when I decided, okay, now it's time to cut back on the medication slowly, especially when it's something like gabapentin. It's not a medication that you can just drop entirely. It's something, again, consult with a professional, physiatrist, your GP. Always consult with a medical professional in those regards, and don't be afraid to. That's one thing I find some people withdraw and they're afraid to ask those questions. Don't be, right? They're there to help you, not to judge you. So going through that process, again, it was a timely one, taking time to get through slowly but surely, and now back to a point of very minimal medication, lots of physical activity, just because it's enjoyable, and I know that it helps me physically and mentally. So in other words, it's kind of my way of kind of taking control of my pain and my life and my activities of what I want to do and participate in. And just being able to combine those is, it's good. It's good. It can also assist you with other aspects of life too, right? Like trying to get, example, going back to school or anything like that. And, it will help to get you in the right mindset to do so. And just really, at the end of the day, I say it's okay not to feel okay. It's okay not to be okay, but just to be able to go talk to somebody in the field of psychiatry, medicine, just to get some insight and some assistance, that's okay too, right? I know a lot of people kind of shy away from the medical or the medication part, but sometimes even a little bit can help. And then in combination with the activity, like I spoke about, Rebecca spoke about, it's a good thing. It helps all full circle. So, and feel free if you guys have questions for us too, to make sure you put them in the comment box and stuff below. And that's a little bit of my spiel for today, and thank you.
Thank you so much, Rob, and for being so generous and sharing your experience. I know it's a hard topic to discuss, and it's great to hear your experience. And so we would like to now discuss this topic, and so we'll move into the discussion period. Please feel free again to use the chat box. I'll watch for the wave of hands for anybody that has questions for either Rebecca or for Rob, and also for anybody else who wants to share their experience as well. Just a reminder, we are going to stop recording as well.